Welcome to the Motivational Midwife. My name's Lynn Jones, and in response to an email I received, today's session is going to be on the Neonatal Energy Triangle. So let's have a look at the neonatal energy triangle. So that's hypothermia, hypoglycaemia and hypoxia, and how they all interact with each other to actually maintain sort of homeostasis for the baby. So if we look at some brief definitions, thermoregulation can be defined as that balance between heat loss and heat production, and those mechanisms we need to employ to maintain that equilibrium. Hypoglycemia would be a plasma blood glucose less than what we would be expecting. So for a neonate, a term neonate, that would be around 2.5 millimoles. Preterm, it's often 2 millimoles is used. And then hypoxia, we're looking at that tissue hypoperfusion, so lack of oxygen to the tissues, which eventually, if we do not rectify, is going to lead to organ dysfunction. So some things to think around thermoregulation. So pregnant women do actually produce about 35% more heat when they're pregnant, and it's, you know, the fetal temperature will raise in relation to that. It's not unnormal for the maternal temperature normally to go up 0.5 degree anyway. But fetal temperature is between 0.3 and 1 degree higher than the mother's. So we are very often encouraging mothers, particularly in the first trimester, that embryonic stage and trimester before the baby is fully developed, not to do anything that is going to significantly increase her body temperature because of that increased temperature to the baby as well. And there have been some concerns linked to increased uterine temperature and teratogenic abnormalities in the fetus. So mother's normal temperature would sit between 37.6, 37.8, and she is really maintaining the control of the temperature in the pregnancy for that baby. At point of birth, that switches, and so there's quite a massive sort of adaptation this baby has to make to then start trying to maintain its own temperature. And that can take a couple of days for that to actually settle and it be able to actually maintain its temperature independently. There is a clear link between temperature control and morbidity. So if we've got babies that get very cold, because those three things in the triangle are very interlinked, the hypoxia and the hypoglycemia, there is a higher risk of morbidity if we have a cold baby. And then think about the methods of heat loss for that baby. So we have got conduction, convection, evaporation and radiation. So we need to consider all of those when we're preparing for birth to see if we can minimize the risks of heat loss through any of those. And we'll talk a little bit more about those shortly. And here is our energy triangle. Okay, so as I've said, if we can maintain a balance between all of those three things, those three elements of the triangle, then we have a stable infant, be it preterm or term. If we can keep all of those things in check, then we have a stable infant. So looking at hypothermia first. So in adults, we would get information. We've got all throughout our body, we've got temperature receptors, and we receive information from those temperature receptors and they go to the hypothalamus. And the hypothalamus is responsible for those autonomic responses that we have in relation to the temperature. So if we're hot, we'll get a peripheral vasodilation and sweating. And if we're cold, we will get vasoconstriction and shivering. The cerebral cortex, when it gets signals from temperature receptors, will have an effect on our behavioural response to that. So again, if we're hot, we will take layers of clothing off. We will take ourselves to a cooler environment. If we are cold, we will put layers on and try and do things and we will shiver and try. That's an autonomic response, but we will try and layer up and move ourselves to a warmer environment, so that we're trying to get ourselves into that thermal neutral zone of 36.5 to 37.5. So in terms of hypothermia for the baby, normal temperature range for the baby is 36.5 to 37.5. A temperature of less than 6 degrees would be hypothermic for that baby and is likely to be, if we don't correct it very quickly, is likely to cause some morbidity because of that connection with the hypoxia and the hypoglycaemia. What will a baby look like then that is got a temperature that is dropping? So it might be pale and quite mottled, extremities might feel cool to the touch. It may not be feeding very well. Certainly if you've got any baby that's not feeding well, one of the first things you should do is check its temperature. It may be quite irritable or crying. It might have poor tone. And because of that link between hypothermia, hypoxia, hypoglycemia, its needs will go up to try and its oxygen needs are going to increase to try and warm itself up. So you're going to likely get an increased respiration rate. So very often you'll get that transient tachypnea of the newborn. So babies, in terms of maintaining their own temperature, we've already said they can't really do it themselves very efficiently for a good 2 or 3 days post-birth. And their ability to generate heat is very much dependent on gestational age, body mass, environmental issues we've said as well. Babies have large surface areas relative to their mass, and the head being about a third of the surface area of the baby. So they are small, wet, and have fluid-filled lungs when they're born, but the small and the wetness bit of it is particularly linked to temperature regulation. So generally when they're born, we usually dry them off, put them skin to skin, put warm towels over them, and usually put a hat on as well to try and minimize that heat loss from the head, which, as I said, is a third of the surface area. So it's going to be the area which loses the most heat for baby. Rarely will babies shiver. Babies don't usually shiver. So if they are hypothermic and we haven't introduced interim measures to try and combat that hypothermia, what will happen is we will get a process called noradrenergic lipolysis of brown fat, or tongues in a twist. That's a tongue twister, isn't it? Otherwise known as non-shivering thermogenesis, which is much easier to say. So the baby will actually start to utilize the brown fat that it has, those brown fat stores that it has. It will metabolize those in order to try and create some heat production. That metabolism of that brown fat is going to release fatty acids, and which will then lead to a reduction in surfactant. And surfactant, as you know, is useful in helping keep those alveoli open, and therefore making the work of breathing much easier for the baby. Eventually, it's going to lead, if not corrected, to pulmonary vasoconstriction. So this baby's oxygen needs are going to go up, and its respiration rate is going to go up. So looking at hypoxia, that's the reduction of oxygen to the tissues. And so we have tissues that are lacking oxygen, So our normal heart rate would be between the range of 110 and 160. Our normal rest rate would be 40 to 60 of a baby that's awake. It might be 30 to 40 in a baby that's sleeping or at rest. So if we've got a lack of oxygen for whatever reason, this baby is likely to increase its respiration rate in an effort to get more oxygen in. And it's going to be starting to metabolize anaerobically because there's a lack of oxygen for it to be able to, the cells to metabolize and function optimally. So it's going to start using up its resources to try and maintain cell metabolism. And that is going to reduce the pH of the baby, and therefore you're going to get a metabolic acidosis and hypoxia. How will that baby present? So we've already said increased rest rate. It may have what's called grunting. So if you've never heard grunting, it's sort of and it's very often accompanied by nasal flaring. So you will see that the baby is making those strange noises. The nostrils are flaring. You might also get a little bit of sternal recession, so you might see those little muscles in between each rib sort of sucking in with each breath. All of those things will tell you that this baby is struggling to breathe and therefore is at risk of hypoxia. You may have poor perfusion, so that baby might be quite pale, and its capillary refill time will be increased, so it's going to be more than 2 to 3 seconds. And that's telling you that perfusion is poor because the baby is trying to prioritize its central organs over other things. And depending on the point, you might get a tachycardia. So if this baby, is already born and its oxygen needs have gone up in relation to something else, then you may get a tachycardia. If it's potentially after birth and it's been a particularly long labour, this baby's been hypoxic in labour, then you may well also get an associated bradycardia. So hypoglycaemia, so when the baby's in utero, then the placenta actually deals with the baby's glucose needs. So it has, the transplacental glucose deals with all the metabolic functions for the baby in terms of glucose levels. When the mother's in labour, of course, it can't actually function at an optimal level because labour is a slightly hypoxic event for that baby. So we do find that metabolism becomes more anaerobic in nature, and so energy needs, glucose needs are going up. And generally speaking, uncompromised babies will cope with that very nicely. But if you've got other things going on in the labour, very prolonged labour, a baby that is becoming hypoxic, this will also impact on the glucose requirements and that anaerobic metabolism. So generally for a term baby, as we've said, we would expect a blood glucose of above 2.5 and above 2 for a preterm baby. Those babies that are hypoglycemic might present with poor tone, lethargy, they may be pale, they very often will have feeding issues, they might have quite a weak cry, they may become quite jittery. And because, as we've said before, those three things are very interlinked, so hypoxia, hypoglycaemia, and hypothermia, it's likely to have an increased rest rate because it's the demands of that anaerobic metabolism is that it needs more oxygen. And we are more likely to have temperature instability. Now, untreated, this will eventually lead to convulsions. So let's put it all together. So if we have signs of hypoxia, we are going to get increased oxygen demand, so our respiration rate is going to go up. We're going to eventually end up with anaerobic metabolism and a metabolic acidosis, leading to hypoxia. If our really important one, hypothermia, so if we can't maintain that temperature, we've got increased metabolism, we have increased metabolism, decreased oxygen consumption, but increased respiratory rate because that demand for oxygen is increasing. We've said we get our anaerobic metabolism, reduced pH, so we'll get a metabolic acidosis, and we're back to hypoxia again. We'll also have that increased metabolism leading to increased glucose uptake because we are needing to have that non-shivering thermogenesis, so we need to use those glycogen stores to generate heat, and we are also going to deplete those glycogen stores, so that's going to lead to hypoglycaemia. Hypoglycemia, we've got our reduced surfactant production, which is going to lead eventually to pulmonary vasoconstriction. So the work of breathing is going to have to increase. We'll get signs of respiratory distress, which are going to lead back to hypoxia. So we've already talked a little bit about brown fat metabolism for the babies when it is having that non-shivering thermogenesis. It's having to use brown fat up to generate heat to try and raise its temperature. So that will release fatty acids, I've said, and that will eventually lead to reduction in surfactant production, and we go back to that pulmonary vasoconstriction and eventually back to hypoxia again. So I hope you can see that they are all very much interlinked. If you have a problem with any one of them, it will eventually, if not corrected, is going to lead to a problem with the other two. So a problem with oxygen supply, we are going to eventually have problems with hypoglycemia and hypothermia. Problems with hypothermia, you will eventually have hypoxia and hypoglycemia, and problems with sugar levels, our hypoglycemia, will eventually, if untreated, lead to hypoxia and hypothermia. So thinking of some of the things we can do to actually correct these things, we can think before birth about environmental factors. So what is the temperature of the room that the woman is going to be birthing in? Have we got windows open or shut? Have we got fans on? Remember, we've said this baby, when it arrives, is wet, so we're going to lose heat certainly by conduction if we have a fan going. And the baby will be radiating heat off as well. If the baby is going to potentially require some resuscitation, what about the surfaces that we'll be resuscitating on? Have we got warm towels? Have we got a heater, a radiant heat source there to try and keep this baby warm if any resuscitation is required? Drying the baby and putting warm towels and blankets on it, putting a hat on to try and reduce it. Most importantly, skin to skin with mother. Skin to skin not only will help raise keep the baby warm, because the mother's body will actually rise 1 to 2 degrees to actually keep its baby warm. It's quite fascinating how it does. And also, it will help regulate the baby's respiratory rate and heart rate as well. Early feeding, if we can get that baby to feed within the first hour, then it is less likely to become hypoglycemic. And if we can facilitate an hour's uninterrupted skin-to-skin post-birth, this is more likely to happen. I appreciate in busy units that that's not always a feasible option, an hour's undisturbed skin to skin, but actually try and do as much as you can. Babies can be examined while they're skin to skin, and weighing can be delayed. There's no great urgency to weigh the baby if it's a level playing field and there's no other issues at point of birth. If you're in a home environment, of course, that is much more easy to facilitate an hour's uninterrupted skin to skin. And then most importantly, educating the parents. Excuse me. Educating the parents on signs and symptoms to look out for of baby perhaps becoming a bit compromised, but more importantly as well, educating parents about keeping their baby warm, not overheating their baby, room temperatures, importance of feeding their baby, and looking for signs and symptoms of compromise in their baby, and referring and getting early help if they are concerned. And there you have it, the Neonatal Energy Triangle. I hope that's been of use to you in helping you understand how each of the things, hypoxia, hypothermia and hypoglycaemia, interact with each other in the well-being of the neonate. If you haven't subscribed to the channel already, please do so. Please spread the word amongst your fellow students and colleagues, and I look forward to seeing you next time.